Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and I recently took care of a patient with omphalitis. I thought this was a great topic for us to get into because it's a fairly uncommon presentation, particularly in developed countries, more common in developing countries, but you could go 5, 10, 15 years without seeing a case, and it's critically important for us to recognize this when it presents to the ED. Omphalitis is a neonatal issue. It's a superficial cellulitis involving the umbilical cord. It typically presents in the first couple of days after birth, but there are cases reported up to 14, even 21 days after birth. And early on, all you might see is simple erythema around that umbilicus, maybe extending to the base of the umbilical cord itself. It can easily be mistaken for skin irritation, specifically that it's in the area where the upper part of the diaper is lying, so maybe the diaper has been rubbing against that area. But one of the ways that we can differentiate it is if you remove the diaper and it's irritation from the diaper, the irritation should improve. Omphalitis won't improve. The area is usually going to be warm. You might actually be able to elicit some tenderness as well. If the patient comes in early, this is a simple superficial infection. But the problem is that these neonates have very immature immune systems and they can't fight off that simple cellulitis. This can very rapidly progress from cellulitis to necrotizing fasciitis, which is obviously much worse. Omphalitis has a morbidity and mortality near 0%, but once this advances, once the patient has more systemic symptoms, or if necrotizing fasciitis comes into play, you're talking about a mortality rate upwards of 60%. And that progression isn't rare. About 10 to 15% of cases of omphalitis will progress to necrotizing fasciitis. So first key point is to recognize this. If you see that erythema, that warmth around the umbilicus, realize that's omphalitis and the patient's going to need aggressive therapy in order to avoid progression. These infections are polymicrobial. You will see gram positives, but you can also see gram negatives and anaerobes, and that's important because it will guide our antibiotic coverage. There's no specific lab studies that are going to be helpful in diagnosing omphalitis. This is a pure clinical diagnosis. You look at that skin, you realize that it is red, it feels warm, you've got the diagnosis, you can move forward. The patient shouldn't have any systemic symptoms if you're just dealing with omphalitis. So you shouldn't see things like tachycardia or tachypnea or fever. If you do see those things, then the omphalitis has already progressed. You already are now at a higher risk for development of necrotizing fasciitis or intra-abdominal infections. If the patient has any systemic symptoms, then we're going to do our full gamut of sepsis labs. We're going to get blood cultures. We're going to do our inflammatory markers, all of the things that are important here. And many infectious disease docs will say, even if the patient looks great and they have omphalitis, do a full septic workup, especially if the patient has a fever. We don't want to just simply chalk it up and say the omphalitis is causing the fever. That's all that's going on. We want to look at the urine. We might need to do a lumbar puncture. We definitely want to get blood cultures. And the omphalitis itself can easily spread to other systems. So even though the omphalitis was the initial insult, the initial infection, the patients can manifest infections in other parts of the body. This is especially true if they already have systemic symptoms present. In the patient with systemic symptoms, look for things like discharge, purulence. The patient may be lethargic and they're going to need substantial resuscitation. The other things that you can find with necrotizing fasciitis, of course, are things like crepitance, rapidly expanding erythema, and signs of toxicity. All that being said about necrotizing fasciitis, if we recognize omphalitis early, if we treat it aggressively, these patients are going to do great. Once you recognize the omphalitis, we're going to treat these patients all with IV antibiotics. The recommendation is to give an anti-staphylococcal penicillin, vancomycin, and an aminoglycoside. Many will also advocate for metronidazole or clindamycin for anaerobic coverage, and that fourth antibiotic is definitely going to be necessary if there are any systemic symptoms. Aside from the antibiotics, don't forget good supportive care, resuscitate the patient, and you want to get both PEDS ID and PEDS surgery on board early for these patients. Even in the patient with simple omphalitis, put in that call to PEDS surgery. You want these patients to be closely followed because they can rapidly progress from omphalitis into an intra-abdominal infection or necrotizing fasciitis. Simple omphalitis should improve within 12 to 24 hours of antibiotics. Most of the time, these patients will go home on oral antibiotics after that. Before we wrap up, let's hit 3 key take-home points. Number one is to stress early diagnosis. If you see erythema and warmth of the skin around the umbilicus, that's not normal. That's not just local irritation from the diaper. Get labs, start antibiotics, and get that patient admitted. Number two, put out your consults to Peds ID and Peds surgery early because progression in necrotizing fasciitis can occur in up to 10 to 15% of patients. And then finally, if the patient appears toxic or has any systemic symptoms, they don't just have omphalitis. This is a more aggressive infection and surgery is likely going to be indicated. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, don't forget to pop on over the site and check out all of the fantastic posts from our faculty. And until next time, stay safe.